It's certainly a pleasure for me to introduce Colin Weeks. He is a native of Nebraska. He went to medical school at UNMC and got his PhD. That's where I met him. He's had a pretty skyrocketing career. He did his fellowship at Johns Hopkins, and now he's at Harvard. He's an associate professor of medicine and director of pancreatic research. Unfortunately, his flight was canceled, so it'd be nice to see him next time he comes to town. So he's going to talk about update on pancreatic cancer and new treatments. With that, Colin, can you hear me?
Can you see my slides?
Yes, we can.
All right, perfect. All right, thank you, Dr. Tarantolo, and I'm really disappointed I'm not able to be in Nebraska today. As Dr. Tarantolo mentioned, I am from Nebraska and a native of University of Nebraska Medical Center, and really that set the stage for me for my career. And so I'm really disappointed I wasn't able to make it. But today I'll talk about sort of what I love, which is taking care of patients with pancreas cancer and trying to help those patients have a better outcome. So let's see here. These are my disclosures. And so I thought I'd start a little bit with background about pancreas cancer. And, it's clear this is the pancreas. And I think it's important to note that, still commonly these patients sort of have these sort of nondescript signs and symptoms associated with the disease, and are commonly diagnosed with other types of maladies prior to being diagnosed with pancreas cancer. And so many times, unfortunately, the disease presents in a very late stage, and we're sort of trying to think about ways to approach late stage disease. I think this is the crux of the problem. So, it's a relatively uncommon cancer. It's the 9th most common cancer diagnosed in male patients, and the 8th most common in female patients. But unfortunately, if you take away the hormonal cancers, it's the 3rd most common cause of death, cancer-related deaths in the United States. And unlike other cancers where the death rate is decreasing with time, sort of pancreas cancer sort of steadily increasing both in females and males. And and by 2030, it's predicted that pancreas cancer will be the 2nd most leading cause of cancer-related deaths in the United States. So this is really a lethal problem that we clearly need more funding to support. But despite all of this, I think we are making progress in the disease. So today I'm going to talk about 2 clinical trials that were presented at ASCO this year that I think are sort of highlight important components of therapy for pancreas cancer. And then I'll talk about some things that are in development or sort of in the nascent stage of development and sort of, I think, hold promise for future therapy. And I always start my talks with pancreas cancer with this slide, which is a slide in which Manny Hidalgo, now several years ago, sort of outlined that there are different components of the pancreas tumor, all of which need to be considered in terms of how to take care of those patients. And so you've got pathways that are associated with the pancreas cancer cell itself, which are sort of outlined here. Oops. And I'm going to focus on TGF-beta for part of this conversation. And then there are these cancer-initiating cells, which also have specific particular pathways that are important for them. And I'll talk about an approach that we are taking to actually address that component as well. And then they have the support cells, like the stromal cells, the immune cells, extracellular matrix, all of those various different components that are important for the disease process. And so we'll touch on some of these different aspects as we sort of move through this talk. So just thinking now about chemotherapy for metastatic disease, and this is really the backbone of all therapy for pancreas cancer. So we started out in 1997, gemcitabine was approved based upon this study, which was done by Skip Burris and Dr. Van Hoff as the senior author. showing that gemcitabine improved minimally improved survival over 5-FU at the time. This was in 1997. But more importantly, this gemcitabine was approved not so much for the survival benefit, but because it sort of improved the symptoms associated with this disease. And it's very interesting. You talked to Dr. Von Hoff, when he talks about this particular study, he talks about the fact that he had this patient who was at the VA and used to go to KFC and eat KFC before coming to get his chemotherapy. He's getting gemcitabine, and how that was a remarkable finding. And if you think about sort of how these patients present, right? So they present with pancreas insufficiency. So if someone who's able to eat fatty foods, you would say those patients would have a challenge with that. Even someone who really has an appetite to eat sort of KFC and not have pain and all those things. And so it's a really sort of fabulous story when he tells it. He's a great storyteller. But at the end of the day, gemcitabine was approved because it improved symptoms associated with the disease. So these are the two sort of landmark studies that we all know about in pancreas cancer. So the one on the right is gemcitabine and Abraxane versus gemcitabine. And this was the IMPACT trial, which showed that patients who received a combination of gemcitabine and nab-paclitaxel, those are the ones who had a better outcome. And then simultaneously, or a few years later, I guess a few years earlier, the PREDIGE group showed that FOLFIRINOX, combination of 5-FU irinotecan and oxaliplatin, improved the overall survival of patients with metastatic pancreas cancer in the first-line setting in comparison to gemcitabine. So most recently at ASCO this year, the NAPOLI-3 study was presented. It was a follow-up of the presentation that was done from GI ASCO earlier in January of this year. So in the NAPOLI-3 study that compared nab-paclitaxel, which is liposomal irinotecan, 5-FU, oxaliplatin versus nab-paclitaxel and gemcitabine. And this was an international study. And here it was patients were randomized 1-to-1 to either arm. Stratification factors were region of therapy, whether or not they had liver metastases, and then performance status. The primary endpoint of this study was overall survival, with secondary endpoints of progression-free survival and overall response rate per investigator using RECIST version 1.1 or safety. And then there were some exploratory analyses that are yet to be performed. And what they showed is that patients who received nab-paclitaxel in comparison to those patients who received gemcitabine and nab-paclitaxel, that there was an improved overall survival associated with that, at the hazard ratio of 0.83. And in that also resulted in improved 12-month overall survival and 18-month overall survival. If you look at progression-free survival, you saw a similar benefit associated with the treatment of nab-paclitaxel with respect to gemcitabine and nab-paclitaxel. And so then this, I think, in the age of equitable care of patients and cost, this then sort of begs the question, is nab-paclitaxel the treatment of choice for this disease? So I think based upon the findings, you would definitely say that nab-paclitaxel does have a benefit in respects to gemcitabine and nab-paclitaxel. It's interesting that when you look at the overall survival of the original PREDIGE study, shown here on the left, the median overall survival was 11.1 months. And you see a similar median overall survival of 11.1 months, almost exactly the same, or you could argue exactly the same, for nab-paclitaxel relative to gemcitabine and nab-paclitaxel. So I think this will be an interesting question for the FDA as we move forward in terms of do they approve nab-paclitaxel as first-line therapy for patients with metastatic disease, and where does FOLFIRINOX play a role in this conversation? You can also sort of ask the question out loud, was nab-paclitaxel plus gemcitabine the appropriate comparator in this study? Now, one would argue that nab-paclitaxel and gemcitabine is the FDA-approved regimen, and that's where nab-paclitaxel is approved. But I think that's a question that I think is an open question and a question that begs to be asked. Now, if you look at progression-free survival, now we're not supposed to sort of do cross-trial comparisons, but maybe there's a benefit of nab-paclitaxel when looking at its results compared to nab-paclitaxel and gemcitabine versus just FOLFIRINOX in and of itself. But once again, I think we'll see. I think that it'll be very interesting to see if there's ever a study done where we look at nab-paclitaxel relative to FOLFIRINOX, because I think that's really the important question when we think about equitable care. And to me, what this says is that the combination of 5-FU irinotecan and oxaliplatin, that's an important chemotherapy backbone, which is, you can sort of chop that up in different ways, whether it's nab-paclitaxel or FOLFIRINOX, but that really is the message that that brings home to me when I think about this study. So the other study that I want to talk about is a study looking at resectable disease patients. And so over the course of time, there's been plenty of argument in terms of what's the appropriate way to treat these patients with resectable disease. Is it adjuvant therapy? Really highlighted by the Purdue study in 2018, where they showed that adjuvant FOLFIRINOX improved the overall survival, disease-free survival, as well as overall survival for patients who received upfront resection in the adjuvant setting, versus sort of some more recent studies. The Pacreatic study, as well as there's a Korean study, showed that preoperative or neoadjuvant chemoradiotherapy does improve outcomes for patients with resectable pancreas cancer. And so that's the backdrop for what was called the NORPACT-1 study. So this was looking at a short course neoadjuvant of FOLFIRINOX versus upfront resection in patients with resectable pancreatic head cancer. And this was done in the Norwegian group of countries. This is the study design. And so patients were randomized either receive upfront surgery followed by 12 cycles of adjuvant nab-paclitaxel, or an EUS biopsy and placement of a biliary stent, followed by neoadjuvant FOLFIRINOX for 4 cycles. And then restaging CT scan, and then those patients who remain eligible for surgery to go on to have surgery, and then get adjuvant 8 cycles of FOLFIRINOX. And with this approach, they showed that patients who received neoadjuvant therapy had an inferior outcome that had a ratio of 1.52 in comparison to those patients who received upfront surgery. And that was with the intent to treat analysis, and per protocol analysis, they saw the same outcome. It had a ratio of 1.46. Now, interesting, if you look at toxicity, they would argue that the toxicity was greater in patients who received the neoadjuvant approach versus those patients who had upfront resection and followed by adjuvant therapy. This is interesting because if you look at the Purdue study looking at adjuvant FOLFIRINOX relative to gemcitabine, only 49% of patients were able to receive 70% of the dose due to toxicity. So a very different sort of outcome than what we see here with this particular study. And then also interestingly, if you look at sort of both the intent to treat as well as per protocol study, the patients who had R0 resection as well as N0 resections, those were preferentially in the patients who received neoadjuvant therapy. And R0 resection has historically been what has been shown to be associated with cure in these patients. So it's interesting that the patients who had the best resection had the worst outcome. And so the question then I think becomes, looking at the chemotherapy and sort of how was the chemotherapy given, and are there any concerns about the design of the study that may impact these outcomes. And I will say for us, we use at MGH, we use neoadjuvant therapy quite heavily. We tend to do a more, I would say, we do total neoadjuvant therapy. So in our situation in general, we use 8 cycles of FOLFIRINOX followed by chemoradiation and then surgery. We don't, in general, use adjuvant therapy for our patients. And what we found is when we do use adjuvant therapy with that degree of neoadjuvant approach, it's very difficult for patients to receive adjuvant therapy in that context. And so I do think sort of this approach of perioperative therapy, depending on sort of how you're designing that, it can be very challenging to give the adjuvant component of that perioperative therapy. So for them, they conclude that neoadjuvant FOLFIRINOX was not the approach to use. I think that still remains debatable. There's the Alliance trial, which is comparing upfront resection versus 12 cycles of adjuvant FOLFIRINOX in comparison to 8 cycles of a neoadjuvant FOLFIRINOX resection and then 4 cycles of adjuvant therapy. So we'll see what the Alliance trial shows, but this I think is an ongoing active sort of component of therapy for this disease and trying to understand this disease. I think also this also provides unique opportunities to sort of incorporate biologic therapies. I'm not going to show any of that work that we're doing related to that today, but I think this is a sort of a unique opportunity to think about how can we incorporate potentially improve outcomes for our patients. So it's been shown that there are different molecular phenotypes of pancreas cancer, similar to what we think about when we think about breast cancer. So for the context of this conversation, simplistically thinking about it, there is the classical or epithelial phenotype, and then there's the basal or squamous or quasi-mesenchymal, depending on what group you stand with, phenotype. So classical epithelial versus basal phenotypes. And so this is a study called the COMPASS trial. And what they did is they looked at patients who had either locally advanced or metastatic disease, who were then classified by either having what's called the Moffitt basal score or classical molecular identification. And this is based upon expression of GATA6 RNA in situ hybridization. So GATA6 is a epithelial gene. And so those patients who are expressing GATA6 have the epithelial phenotype. They treated all patients with FOLFIRINOX, and they asked sort of what's the outcomes associated with that. And so what you can see here is that patients who had the classical phenotype, GATA6 positive, who are in purple, those patients preferentially responded to FOLFIRINOX. Conversely, those patients who had the basal phenotype, those are the patients who preferentially have resistance to FOLFIRINOX. And this was associated with an improved progression-free survival based upon GATA6 expression. So this suggests that, in fact, patients who have an epithelial phenotype, those patients should preferentially be treated with FOLFIRINOX. And so it may be that if we can sort of determine patients' molecular phenotypes, we might be able to sort of stratify patients or choose therapies for patients based upon that particular classification, and hence a way to think about personalized therapy for patients with pancreatic cancer. So this is some work that was done by my colleague David Ting in his lab, in which they showed that they can, using RNA in situ hybridization assay, they can sort of dually stain patients for either epithelial markers or quasi-mesenchymal or basal markers. He's now developed this into a CLIA-approved assay. So we can potentially look at whether patients are epithelial at baseline versus a mesenchymal, and think about how we should treat those patients with, say, FOLFIRINOX versus potentially maybe NAB paclitaxel and gemcitabine for those patients who are mesenchymal. So David went on to show that, in fact, TGF-beta, which is produced by the stromal cells, is an important determinant of this process. So what David showed was that the majority, if you go back one slide, the majority of our patients, when they are sort of treated initially, are untreated patients initially baseline, the majority of our patients are epithelial in nature. And then as they get treated with FOLFIRINOX, and this is in patients who had resected disease, that 2/3 of those patients now become mesenchymal, and so it becomes sort of a switch from an epithelial phenotype to a mesenchymal phenotype associated with treatment. And so we asked in the lab now, what's sort of driving that outcome? And so what he showed was that that cancer-associated fibroblasts produce TGF-beta, and this TGF-beta is important for this class switching. And that class switching is now associated with resistance to FOLFIRINOX. And so the concept is that if we could potentially inhibit TGF-beta production or suppression or pathway activation, that potentially we could prevent this conversion from epithelial to mesenchymal phenotype, and then prolong the response or the benefit that our patients are receiving with FOLFIRINOX therapy. So another group in Scotland showed similarly that GSK3 beta is an important driver of the basal phenotype, and then glycolysis, which is a metabolic pathway that's associated with the basal phenotype. And so between these two papers, there's evidence that TGF-beta as well as GSK3 beta are important mediators of this molecular class switching associated with FOLFIRINOX exposure. And so, as Dr. Tarantolo stated, I was a medical student at University of Nebraska. I'm a native of Nebraska. I grew up out here in Alliance. And I remember every holiday I'd have to drive from Omaha to Alliance to see my mom. My mom would not let me not come home for the holidays. And as you know, we usually have tests around the holidays. And so how I used to think about driving from Omaha to Nebraska was from Omaha to Alliance is I would drive to Grand Island, take a break, drive to Broken Bow, take a break, drive to Thedford, take a break, and then drive to Alliance and take a break. So you're saying to yourself, why in the world are you telling us this story, Colin? So I want to talk about how I'm thinking about modular therapy for patients with pancreas cancer. Very similarly, right? So currently we treat patients this way, right? So FOLFIRINOX, in this case, plus TGF-beta until there's evidence of disease progression. But what if we did this? We treated patients with FOLFIRINOX, TGF-beta, modular therapy, sort of debulking therapy, similar to how we think about treating leukemia patients, right? So we're going to debulk their tumor, and then we're going to get to this component where we have these cancer initiating or cancer stem cells that are really sort of dependent upon their microenvironment, but they have different molecular susceptibilities than, say, the bulk tumor does. And so in this example, we then now talk about immune priming. And one of the work that our group is doing, our radiation oncologist is doing, is looking at if we give radiation to metastatic foci, can we induce an immune response such that when we add immune targeting agents, that we actually improve the immune response and then are able to target all of the metastatic foci, not just the one that's irradiated. And so that's an example of potentially how we could utilize immune priming to sort of support this concept. And then now moving on to maintenance therapy, where we're just sort of maintaining this sort of very low burden of disease. That's these cancer initiating cells that really aren't very metabolically active. But we also know at some point that those cells are going to outgrow that pressure, and then we would come back with debulking therapy. And so this is an example of a trial that we currently have open that's really sort of utilizing both of these approaches. So the study is a multi-arm study in which patients are randomized to either receive FOLFIRINOX plus losartan. So it turns out that losartan, although it's a blood pressure medicine, members of our laboratory scientific group at MGH has shown that losartan is important for inhibition of the production of TGF-beta. And so I think of it as a poor man's TGF-beta inhibitor. And then this 99G41, which is now called elraglusib, is a GSK3 beta inhibitor. And then so patients are randomized to receive either these biologic agents alone or in combination with FOLFIRINOX. The study is designed such that there's only 5 patients in the combination arm and 20 patients in each of these arms. And really, the cool thing about this study is that we're boxing patients serially on therapy. We're also using this, what's called peroximetol MRI. And so peroximetol is iron particles. And since macrophages take up iron particles, we can look at sort of macrophage trafficking within the tumor as we're sort of treating the patients on study. And so we're serially doing these peroximetol MRI imaging. And then we were also serially doing liquid biopsies of these patients. And so these patients receive this complete therapy for 6 months or 12 cycles. And then patients then move on to maintenance therapy, which is just 5-FU plus whatever their biologic agent that are on. And then they then move back on to complete therapy when they have evidence the tumor is growing while on maintenance therapy. We did an initial safety cohort of 6 patients with this combination therapy. And what I can tell you about those 6 patients is that 3 of the 6 patients are now over a year on therapy. 2 of the 3 are here, and one of the 3 is here. So really sort of initial fascinating data that we're seeing, and we're really excited about what this therapy potentially holds for our patients. So I think the other sort of exciting component of therapy going forward is RAS. So as many of you know, RAS is the most common mutation that's associated with pancreas cancer. It occurs in probably 95% or higher patients with pancreas cancer. Historically, this has not been a druggable protein. And in the recent decades, we've sort of now seen that RAS potentially is a druggable protein. So this is a very busy slide of a poster that was presented at ASCO this year. But the point of this poster is that there are multiple different isoforms of the RAS mutation that occur in pancreas cancer. The most common one is G12D. Next most common are G12R, G12V. And so what this poster did is they looked at the outcomes of patients here based upon their RAS status, as well as looking at their immune profile based upon their RAS status. And what they sort of concluded is that different RAS proteins have different molecular consequences, which then result in varied immune response, varied clinical outcomes. And this is the exciting paper, I think. So this is looking at sotorasib in patients who have G12C mutant pancreas cancer. So this represents about 1 to 2% of patients with pancreas cancer, so a very rare patient population. However, it's very interesting that in this situation, when you treat these patients with sorafenib, about 30–40% of patients respond to sotorasib, and that was associated in patients with advanced disease, associated with the progression-free survival of 4 months and an improved overall survival of almost 7 months in patients with very aggressive disease. So it'll be interesting to see when we move this type of molecule to earlier in the disease setting, do we see better outcomes for these patients? But more important, I think what this demonstrates is that targeting RAS and the various isoforms of RAS is going to be an important treatment pathway going forward for our patients and maybe result in significant outcomes for our patients. And so there are now KRAS G12D inhibitors, and G12D is the most common mutation in pancreas cancer. So there are those are sort of now sort of starting in the phase 1 component of clinical investigation. So hopefully soon those will be more available for our patients with pancreas cancer. I can't remember if I have, oops. Yeah, and so I was going to show another slide, but there's, now I'm looking at RAS-based vaccines. We're seeing some very interesting things with RAS-based vaccines and trying to harness the immune system. It's also been demonstrated that the combination of RAS inhibitors with immune targeted agents may also be a pathway to go forward. So I think there's lots of enthusiasm around different ways to target the RAS pathway, MAP kinase pathway in patients with pancreatic cancer. And so I'm part of a very large team of scientists and clinical practitioners at MGH. I'm also working very closely with friends at Hopkins, as well as friends at University of Colorado, where I used to be prior to being here at MGH. And so with that, I'd like to thank you for your time. I use this slide because he unfortunately had pancreas cancer and died of this disease, and for me reminds me of the importance that we all need to focus on this disease. So I'd like to thank you for your time, and I'll take any questions that you may have.
Does anyone have a question?
So, I'm sorry.
Can you hear us, Colin?
Yeah.
Okay.
So, a question is about pancreatic cancer, the role of radiation therapy, because at the tumor board we go back and forth. The surgeons tells us that they, whenever the patient got chemotherapy or radiation, it's easier to operate and easier to remove the tumor and easier to remove everything. So, and we just cannot come to conclusion. The data are so contradicting sometimes. It's difficult to kind of have a really handle on how to deal with a pancreatic cancer that is resectable or potentially resectable. How do you view the role of radiation?
That's, I think, the $1 million question. So I happen to be at a center that is a radiation believer. But you're right, the data is very complex and mixed. So I showed the 2 studies, a PREOPANC study as well as this a Korean study. Those are both randomized studies where they showed that patients with resectable pancreas cancer, that giving those patients chemoradiation, actually 2 different forms of chemoradiation, improved the survival for those patients. I didn't show is within our own group, we have been looking at neoadjuvant therapy for some time. And what we have shown is that in patients who have either borderline resectable or even locally advanced disease who then turns resectable, that those patients who get total neoadjuvant therapy, including radiation. So let me just back up. So our total neoadjuvant therapy is 4 months of FOLFIRINOX, and then, traditional 5.5 weeks, 54 gray chemoradiation. And so in those patients who are able to have surgery, their median disease-free survival is around 48 months versus those who are not resected, their median survival is around 11 months. So we would argue that radiation is important for that patient population, but you're right. So if you look at SWOG study and others, it's muddy, right? And part of it is, I think, how the radiation is administered matters. some of the studies that are out there, the largest studies that are out there are institutions who are giving 1 or 2 patients very complicated radiation. I've seen many times when working with my partners in our multi-D clinic where patients they're not like what is thought to be the pancreas and what's being irradiated, the cancer is not actually the cancer. So I think it's really important we have to sort of come to some more unified approach to radiation therapy. And I think even if you go back to the SPAC studies, back in the day, that was one of the major concerns with the SPAC studies, and how do you, especially SPAC 3, where the radiation therapy was not unified amongst all the centers that were giving radiation, and that ultimately probably had a negative outcome. So I think you're right. It's very challenging to think about how to use radiation. I think objectively, our approach is to use radiation. Our surgeons are very particular, and want our radiation oncologists only to do the radiation for them. So I think the technical skills of the practitioner matter. Just as I think when I refer to that NORPAC study with the neoadjuvant FOLFIRINOX versus the adjuvant FOLFIRINOX, I think the practitioner's ability of chemotherapy matters too, right? So as I looked through that study, and I didn't go into very much detail about it, but there's some significant questions about chemotherapy as well. And so I think this concept of sort of centers of excellence in taking care of this disease is important.
Thank you.
So Colin, are there any other TGF-beta inhibitors? I know people looked at thalidomide in the past with some things with NOS.
Yeah, so I didn't show this, but I thought I wouldn't have enough time, so I didn't show it. But we are actually working very collaboratively. We have a really cool study with Novartis. So Novartis has a compound called NIS 793, which is a monoclonal antibody against TGF-beta. So the TGF-beta compounds that have been used in the past are small molecule inhibitors of the receptor. And in particular, they were sort of pan inhibitors of the receptor. And so that resulted in thrombocytopenia as well as cardiovascular sort of heart failure sort of episodes in patients. So this TGF-beta compound that I'm talking about is a TGF-beta 1 targeted monoclonal antibody. And so we are we have a study that's open right now where it's really morphed in this really cool project where there's a cohort of patients with resectable pancreas cancer who are getting treated with neoadjuvant therapy. These are proof of principle studies, but basically it's 5 patients with FOLFIRINOX, 5 patients with FOLFIRINOX plus the NIS 793. We're simultaneously biopsying those patients. We're doing RNA site 2 hybridization on those patients to look at the class switching. We are doing collagen-based PET imaging to look at the fibrosis of the tumors over time with therapy. And then we're also doing, you can do elastography with endoscopic ultrasound. And so we're doing elastography to look at sort of the fibrotic nature of the tumor for changing that with time. So we're doing a similar study. There's another cohort in that study is now looking at patients with locally advanced disease or borderline resectable disease, similar approach. But instead of doing the collagen assay, we're doing the peroxidase MRI that I showed you before, and then we're also adding tislelizumab to look at immune modulation. And then there's also a metastatic disease cohort. So this TGF-beta compound I think it holds promise in this disease. We've seen some sort of unique outcomes so far, but it's very early days. So that is a TGF-beta compound that I'm aware of. I think there's another one there's 2 or 3 other monoclonal antibodies that are currently in development in different diseases.
Well, thank you very much, Colin. It was a great presentation.
Thank you. Hopefully sometime I'll be able to come out and see you all down in Nebraska. So I apologize for not being able to make it today because I was looking forward to it.
Thank you.
Thank you.